Welcome. We are so excited to have you join us today as we discuss insights and strategies for navigating Medicare. So this is a super important topic, and we're very excited to bring this information to you in advance of Medicare's annual open enrollment. So as many of you know, many of you on the call today are already on Medicare. So open enrollment starts October 15th and then continues through December 7th. And annual open enrollment is an opportunity for you to review and make changes to your health plans and drug coverage for next year. So before I introduce our guests, please know that this webinar is being recorded. And as always, we will post our replay to our website, evansmay.com. Thank you for all of you who submitted questions in advance of the webinar. If you have any questions for Karl during the webinar, please enter them using the Q&A feature that you can find by hovering over the bottom of your screen. So your submitted questions are anonymous unless you elect to submit them so that others can see them. And then Karl will leave about 15 minutes at the end of the presentation for Q&A, and Emily will come on and facilitate those questions. So now on to our esteemed speaker, Karl Steinlage. Karl is the broker owner of Steinlage Insurance Agencies. So they have been helping families with Medicare Advantage, Medicare Supplements, Medicare Part D since the 1970s. Karl and I worked together on several client families, and we are super grateful and thankful for him to join us today and share his insights and expertise. So without further ado, let's get started. And Karl, I will turn it over to you.
All right, thank you. Well, appreciate everybody attending. I'll jump right in because I've got plenty to share with the magical world of Medicare. So quick background on our agency. I'm actually located in St. Louis, born and raised here. Our agency is licensed nationwide. So we're in all 50 states, able to help retirees kind of figure out healthcare, or really anybody that is in a position to have to navigate healthcare away from employer coverage. Oftentimes we find it's kind of the first time this becomes a necessary evil for you. So for that reason, the fact that it's expensive, it's confusing, your health is the most important thing you have. You strive to stay healthy, but hey, stuff happens as we get older, and it's expensive. So it's a very important topic to get right. So we are, I think, in a great position to be able to help clients navigate the transition between COBRA, group insurance, a gap in a Medicare, signing up for Medicare, which happens at 65. We'll kind of talk about if you're new to Medicare here in the next year or two, what you have to look forward to. And then once you're on Medicare, making sure that you don't set it and forget it, and understanding that the plan you picked out 6 years ago might have been the most comprehensive plan at that time, but things change and new plans come out and your health changes and medications go generic and you might add new prescriptions. So making sure that we're not missing anything obvious within a Medicare review is something we provide. And then we'll talk about everyone's favorite acronym, IRMAA, which if you're unfamiliar, we'll get into that as well, and what you can do to minimize some of the consequences, if any, on IRMAA. So jumping right in, Medicare starts at 65. So a lot of people listening to this webinar might be in that kind of calm before the storm of a few months or a year or so before you're 65. And what you'll start to notice is that as you approach 65, you start to get a piece of mail about Medicare, 2 pieces of mail. And then when you enter what's called your initial enrollment period, which is the period that starts 3 months before your 65th birthday, the month of your 65th birthday, and 3 months after, you start to get 5 to 10 solicitations a day, phone calls, emails, Facebook messages, people stopping by your house. It's pretty crazy, but we hear the term inundated a lot. People feel inundated with solicitations. And I kind of kid, if you forgot how old you were, the private insurance world will kindly remind you that you are turning 65 5 to 10 times a day during that process, or during that transition into Medicare. And so the reason why there's all this marketing noise around Medicare is because it's one of those rare situations where oftentimes we feel forced to make a decision. And we hear all the time that people are worried about a penalty, right? I don't want to mess something up. I'm turning 65. My friend told me this. I read an AARP article that told me that. My parents told me about their experience 20 or 30 years ago. And so I don't want to mess this up. And one of the interesting things that has kind of shifted over time is when Medicare was first designed back in the 60s, I would say the norm, probably everybody was already retired when they got onto Medicare. And so they just naturally dropped their group insurance or their retiree healthcare and moved right into Medicare. Whereas today it is very common for people to still work past 65. So one of the things that we help with is navigating what is the right thing to do when we turn 65. And it's different for everybody, but really there are 3 doors that you can walk through when you turn 65. And based off of your specific situation, that will dictate which door makes the most sense for you. And I could spend all 45 minutes on this slide talking about all the little nuances. You know, what if I have a kid in college? What if I am single? What if I am married? What if I have a really expensive prescription? But when in doubt, you'll have my contact information. You know, just a quick 5 or 10 minute phone call, even an email exchange, I can get you to the right door. And that way we make sure, most importantly, that you're not doing any harm or, you know, going through things that you don't need to. But we want to do this right the first time. This is one of those things that if we can set you up properly, it really makes that end experience that much better as you transition into whatever that is. So the first door I'm going to talk about is what I'll call door number 1, which is to do nothing. So I would say a lot of clients that we work with in the wealth management space, this is what they end up doing because they are on an employer plan with a large employer. So the key here for door number 1 and door number 2, where if we don't move you all the way into Medicare and pay for the Part B premium, the kicker is 20 or more employees. So if we're less than 20 employees, things change where now Medicare becomes primary. So the advice there is going to be a little bit different. But the assumption is that you're working for a large company of 21 or, you know, thousands upon thousands of employees. So if that's the case, if you are covered by your own employment or a spouse's employment, there are no penalties to worry about. So we don't have to tell the government that you're going to stay on group insurance. And if you have a health savings account, which is a great tool to minimize your income and help save for healthcare and retirement, then that is going to push you through door number 1 because you can fund your HSA after age 65 as long as you do not enroll in a Medicare Part A. So that is a common mistake we see people make is they'll meet us a year or 2 later and they'll accidentally, because of this fear of a penalty, sign up for Part A, which then limits your ability to fund that HSA. So if I'm going to work till I'm 70 and I pay nothing for my employer health insurance and my employer is kicking in $2,500 a year into the HSA, door number 1 is a very obvious solution. There's no need to go pay for Medicare because you have a very inexpensive group plan and you're enjoying free money from your employer and then maybe matching that and taking advantage of the tax efficiency of a health savings account. The advice there would be to go through door number 1. Now, if you're not on an HSA, so we would call that like a traditional plan, like a PPO plan where we have a copay at a doctor, we have a copay at a specialist, a copay for prescriptions, then I think it would make sense to look at the cost you're paying for your employer plan and compare that to the cost you get with Medicare and the benefits of supplemental and Medicare Advantage. And if it makes sense for you to stay on your PPO style employer plan, then the advice we would give is to kind of get your foot in the door and take what we call the free part of Medicare, the hospitalization portion, which is Part A only. And the reason we would make that recommendation is, one, is that Part A doesn't cost you anything. So there is no added cost. Part A becomes secondary. So you still operate just like you have been with your group insurance card, but now you're kind of more ready to go upon retirement. We've already got your Part A benefit set up. You've already got your Medicare card. So sometimes we see people's transition into Medicare happens very abruptly because of a health event. And so in that situation, having Part A in force back at 65 already gets you kind of halfway to the finish line and helps us move you the rest of the way that much faster, given the urgency of a potential situation. But the main thing is that you are not funding an HSA. So if you're not on an HSA plan, again, no penalties. So sometimes people will just opt for door number one because it's the path of least resistance. That's totally fine as long as you're on that employer plan through you or your spouse's full-time employment, and that group has more than 20 lives. Door number one or door number two will not generate a penalty when you decide to move into Medicare upon retirement. So in that scenario, what we're doing is we're keeping the group plan primary. We're either doing nothing or getting our foot partially in the door with Part A, and then we're going to delay enrolling into Part B, which is the portion we have to pay for, until we no longer have that group sponsored plan. So upon retirement, which could be in 6 months, 67, 70, whenever it might be, your window to move into Medicare is really open-ended based off of when you decide to call it quits. A severance package, a health event, just a change in leadership, whatever it might be, somebody can move to Medicare today to start October 1st, today to start November 1st. They could wait until February of next year. You have a lot of flexibility if you delay your Part B enrollment because you're on group insurance, and you can decide when you want to move into Medicare, but Part B, and then through door number 3 based off of when you retire. I will say that we are seeing more and more people that are on employer-sponsored coverage compare what they're paying for their employer plan, what their deductible is, what their copay is at the doctor, copays for prescriptions, and then letting us evaluate how much Medicare would cost you and what that Medicare option would look like. And more often than in previous years, we're finding that people are voluntarily dropping their employer plans. They have no intention on retiring. So moving to Medicare at 65 is really based off of what makes the most sense for you. So if you are on a small company plan, you have to move to Medicare because of these coordination of benefits issues. Or maybe your employer plan has a really high deductible and you're paying $300 or $400 a month for it. Well, in that situation, it might make sense for you to drop your employer plan totally, sign up for Part A, which is free, sign up for Part B, which has a monthly premium. Today, that standard monthly premium is about $175 a month. But then, as we'll see in a second, they means test your Medicare fees. So another important piece of information into this equation, besides doctors, prescriptions, household demographic, the guts of an employer plan, what is the deductible, what is the copay, what is the premium for employee only, employee plus spouse, is how much your adjusted gross income is. Because certain earners over about $100,000 if we're single and $200,000 if we're married filing jointly, the government requires them to pay more for their Medicare, which can make moving through this option less attractive if we have a, marginally expensive employer plan, right? If my employer plan is $400 a month and I make less than the IRMAA cutoff, and my Medicare fee is only $175, I might be inclined to move to Medicare. But if I make $1 million a year, my Medicare premium is going to fluctuate up to about $700 a month. That makes that $350 employer plan look a little more reasonable. But I would not automatically assume that if you're on an employer plan, that Medicare is not a good deal. And so that's a service that we provide at no cost to you, is to just evaluate which door makes the most sense. In that way, you know that you are getting into the Medicare program properly. So if most people listening to this webinar, if we're not on Medicare yet, we're working still, we have younger spouse and kids on our group plan, and we're on an HSA compatible plan, we're going to go through door number 1, and we're going to delay all parts of Medicare until we retire. And so this next little bit of advice is for people that are in that scenario. And what you need to be mindful of is that when you do retire and you start to chip away at getting into Medicare, which eventually needs to happen, your HSA contributions need to be prorated in the year that you move to Medicare, because when you enroll into Part A by itself after age 65, then your effective date of Part A is 6 months retroactive. So I'll give you an example. Let's say I turn 69 this year and I am going to retire January 1st, 2025. And so I went through door number 1 back at 65. I delayed it. I have funded my HSA at 65, 66, 67, 68. And now I have fully funded my HSA for 2024. Maybe I did that right at the beginning of the year, or I'm doing it in a prorated amount up through the end of the year. The catch is that when I go to sign up for Medicare Part A, which is the first step of building this bridge to Medicare after 65, if I did that today in September, I would have an effective date of March 1st, 2024. And that's because of this 6-month look back. And so now I have an issue where I fully funded my HSA this year, and I should have had a partial funding for this year because I have an effective date earlier in the year. So the main takeaway on this is to make sure that we are sensitive to that 6-month look back on our HSA and fund the HSA accordingly in the year that you're moving to Medicare. Sometimes people will just set the funding at 0, knowing that they're retiring at the end of the year, and then maybe figure that prorated amount out at the end of the year. Now, if you're getting an employer contribution, you probably don't have the ability to, say no, thank you right now, give me that money later on. But let's just make sure that we understand that HSAs are awesome tools. We can use HSA dollars really at our discretion after we retire. So that bucket of money is yours to carry with you. But the funding in the year that you move to Medicare creates a little bit of an oil and water situation where they just don't play well. So 2 ways to sign up for Medicare. One is an automatic enrollment. So if you enroll into Social Security benefits prior to 65, then you will just be automatically enrolled into Medicare without even doing anything. And so that card shows up in the mail approximately 4 months before your 65th birthday, right in the middle of all of this marketing material. So another kind of common heads up would be, if you're drawing Social Security, don't throw away your Medicare card. We see people all the time accidentally throw away the Medicare card because it looks like a lot of these advertisements you're getting for supplemental insurance. If you're not drawing Social, which for the higher income crowd is typical, where we're going to delay Social Security until 67, till 70. And even if you're retired, that may be the right decision for you. But now we want to take Medicare at 65 because we're on COBRA or Marketplace, right? And to back up a quick second, if you are not on an employer-sponsored plan, which would be considered COBRA, even if it's subsidized by an employer, Marketplace coverage, even if you're getting a significant subsidy, or unsubsidized Marketplace or Obamacare, a retiree plan through a previous employer, then that is going to push you through door number 3. So the only way to delay Medicare A and B without a penalty is to have an active employer-sponsored plan Otherwise, all roads are going to lead us through door number 3, which means that we're going to need to enroll into Medicare A and B through the ssa.gov portal. So this is the same website that you would use to go check your Social Security balance or activate Social Security. Medicare tasks the Social Security Department with signing you up. After that, those two systems really run independently. So one of the things that we've had is changes in the login credentialing for ssa.gov to where a number of people have been locked out of this account and really not worried about it. So if you fall into that category, if you cannot enroll or log into your ssa.gov portal, I would encourage you to go through the frustrating process of resetting your password, getting the PIN number mailed to you, sitting on hold for an hour, because that process can take 30 to 45 days. And if we have a dilemma or a crisis on our hands where you haven't done any of this and now a health event kind of throws you into needing Medicare ASAP, we have this roadblock to get you into Medicare. And that can be very frustrating now when you have a deadline versus maybe today there isn't the stress of a deadline looming. So that would be just kind of a pro tip, I guess, is to make sure that you can at least get into ssa.gov and then allow us, or based off of the webinar, if you feel comfortable picking the path that you're in, then we would just go through either door number 2, signing up for part A only, or door number 3, A and B together, by logging into your ssa.gov account. If you have what I would call kind of unique situations, teachers and educators, clients that are not in the system fully, right? To get Medicare on our own record, we have to pay into the system for at least 10 years or 40 quarters. Then we are finding, because of staffing issues, that it is taking clients much longer than you would anticipate to get your Medicare processed. So going back to that, I'm working past 65. When is the right time to start messing with Medicare in relation to retirement date? I would love to have a conversation with you, 4 to 6 months in advance of that date, just so we can get acquainted with, here's, how we get you in the system properly, and we don't hit these timing snags that can really stress, the system and, have you anxiously waiting for your ID cards on December 31st because you need that coverage to start January 1. So when in doubt, let's give ourselves a little extra time, 4 to 6 months rather than that 3-month kind of 90-day window that we've heard before. So when we talk about going through door number 3, moving to Medicare, we have to pay a monthly premium to Medicare. That premium changes every year. And then that premium is mean tested based off of your income from 2 years ago. So this is IRMAA, income related monthly adjusted amount. So I'll use that example of I'm retiring on 1/1/25. I'm 67. So I have been ignoring all of this on my very inexpensive group plan, but now it's coming to an end. And so the price that I pay for Medicare is based off of my 2023 household modified adjusted gross income. And so MAGI, or modified adjusted gross income, is going to be the same for a lot of clients. It's going to be investment income. It's going to be wages. It's going to be deferred comp. It's going to be 100% of Social Security income. It's going to be stock options, right? It's more or less the number you don't want it to be, kind of the highest number from what I've seen, with very little, if any, deductions. So we simply go find where you fit on the bracket. And let's say you make $1 million a year. And we don't know the numbers for next year. So this chart is for 2024. I would go ahead and say that everything is just going to kind of increase about 5% for next year. So what I've read is that this bracket might move from 103 to about 106. We might go to about 212, but we're given an election year, everything just takes longer to hear from the government. But these brackets are inflation indexed every single year. And then the Medicare fee, the standard fee, that $175, will go up for everybody. And then these shift as well. So on January 1st, 25, I move into Medicare and I pay Part B. And if I was making $1 million, then my Medicare fee increases by about $500 a month. So the way we read this chart is I buy Medicare at the base fee. The government adds a surcharge for my Part B. Then when I purchase drug coverage, they add another surcharge to add up to $675. So I pay that to the federal government, no matter what purchase decision I make. Supplement, Advantage, which we'll talk about. This is kind of your sunk cost into Medicare. And you can see if you have a $300 a month group plan, that Medicare doesn't look so attractive here. But if you're working part-time or in a consulting role, or your income is just under this $206,000 cutoff, then the Medicare fee, it looks more attractive compared to an employer plan. So that's why income is so important when we're talking about should you move to Medicare or not, because that can make or break the recommendation. Many clients come into Medicare with a drop in income. Yes, I made $1 million in 2023, but now in 2025, my income is going to $100,000, or, people will say zero, but oftentimes that's not the case because you have investment gains, Roth conversions are going to count towards this as income. But if you can substantiate a drop in income because of one of these life events, and work stoppage or work reduction is easily the number one life event, then you can have the government reassess IRMAA. And that's a service we can help you with. But more or less in that situation, I could argue that, yes, my income was $1 million in 2023, but in 2025, my income is going to be $250,000. I'm getting a one-time payment from the sale of my business, plus, what Evans May and you have, keyed in on what investment income might look like. And so we think 250 is a fair assessment. And if you raise your hand, the government will use that estimated amount right out of the gate in 2025. You won't have to wait until 2027 to look back at 2025. So that IRMAA appeal can really be helpful because it can reduce your Medicare fees much faster than what you thought. And now a lot of clients have, a very black and white situation, which is what I'm describing. Your income drops and we know what that number is going to be. But a lot of clients also have a lot of uncertainty with income, dividend income. Maybe you're loaning money to your kids and they're paying you back. You have, investments that are going to fluctuate based off of the stock market. You have, consulting. I kind of kid. My dad sold health insurance. He owned our agency, and his path to retirement was about a 15-year glide. And my mom was a trauma surgeon. And so she went from being 1,000% employed to 0% employed overnight. And you can't really be a moonlighting trauma surgeon or part-time trauma surgeon. You either on call 1,000% on or 0% off. In the financial services world, you can kind of slowly but surely, shift gears, dial back, whatever. And so in that situation, we had a very obvious end of our disruption of income versus a much longer, glide into a lower number. So when in doubt, we kind of recommend the accurate but aggressive, or you would rather appeal and have to give back the money you should have owed than to not appeal and realize, a year or two later that your income actually was 250, not 300,000, and you were stuck on, not knowing which one to pick because it was an investment opportunity that may or may not, pay out in 25. And this is just my personal opinion, I would rather come in, pay the lower amount, and understand that if I miss that number, I will owe the difference back. No interest, no penalties. But if I come in and I estimate a little higher than what I thought just to kind of be safe or conservative, that's still okay, right? We're talking about dropping your premium from $675 to maybe this bracket. But then if you found that you should have been here, the government doesn't give you that money back. So hopefully that's helpful. So then we kind of move into the decision that you have on Medicare. So this will bring in a lot of people that are already on Medicare, because when we have Medicare, this just pays 80% of our bill. right? So if I just bought original Medicare A and B, the issues with that and why there's all this extra insurance that people buy is that doesn't cover the 20% exposure that's left behind by Medicare. So if I just have original Medicare and I show that red, white, and blue card, I'm responsible for 20% of whatever is left over, and there's no stop loss or max out of pocket. There's also no prescription coverage, and there's no dental and vision. So that really kind of forms the, you need to pick a path here to do the job properly to kind of mimic what we've had through the employer market. And so this is where we talk about supplemental insurance. If anyone's ever heard of like Plan G or Plan F, that is what I would call kind of the Cadillac. That is the most expensive option you can pick, but also the most comprehensive. I would say most wealth management clients are still trending this way because they feel like they can afford it. They want the best, the most flexible. And the rules on this say that you get one chance to buy supplemental insurance without answering health questions the first time you get into Medicare. So if we don't go down this path out of the gate and we come into Medicare Advantage and we want to leave Medicare Advantage later on because we don't like some of the restrictions, then you have risk to where you may not be insurable to buy that Medicare supplement when you have health issues. So the way that this path works is we're building on top of Medicare plus whatever IRMAA charge we may have. So going back to that previous example, let's say I drop my Medicare fee to $257 a month. I'm paying the government $257. That is invoiced to me quarterly until I start drawing Social Security. Once I start drawing Social, then that comes out of my Social Security check for the rest of your life. What you pay to Medicare and any IRMAA surcharges is an HSA allowable expense. So for higher income clients that are going to be spending $500 or $600 a month, presumably forever because they have high income forever, then loading up on that HSA from 30, 40, 50, 60 all the way up till Medicare is a great idea because we know you're going to have enough, there's going to be this big allowable expense that's going to follow you forever. So we pay Medicare, and then if we go the supplemental side, we're buying a Medigap policy from some insurance company, and that is going to look like this chart. So as it stands right now, Plan G is the top of the line coverage you can buy. So a lot of clients we work with, they're not, we don't want to waste money, but we're not price driven to where I need to buy the cheapest insurance possible and I'll change all my doctors around. A lot of clients say, hey, within reason, I can afford whatever it is. I want the best coverage possible. That is my goal with this. That's a very easy recommendation. Go buy a Medicare supplement Plan G from whatever carrier makes the most sense. And that's where we can help you identify what companies have spousal discounts, what companies have the lowest rates in your area, what companies have a good track record of keeping premiums stable. Because one of the negatives of supplemental insurance is that the price goes up. But the supplement wraps around Medicare. So it is going to let you see any doctor that takes Medicare. So I don't have to vet the network of a AARP supplement. If your doctor has a big sign that says, we do not take United Healthcare or Blue Cross, even if you have a Blue Cross supplement, you can still see that doctor because Medicare, red, white, and blue Medicare is your primary payer. They dictate where you can go, what's covered. And right now, 98% of all providers in the country take Medicare. And Medicare also is what we call fee for service. So there's no pre-authorizations, there's no networks, there's no pre-approval process. And that supplemental plan is along for the ride. So the supplement cannot institute pre-approvals or managed care referrals, that type of stuff, which is what a lot of people love about this path is I just go where I want and it's covered. I don't need to check a doctor if I'm traveling or if I have multiple residences. I just go and it's paid for. And that's what I like about selling supplemental insurance is that we know over time, if we live long enough, we're going to use this. And at that time, if you want the freedom to go where you want without scrutiny, then supplemental makes the most sense. Most supplements are going to run Like in Indianapolis area is probably a shade lower than the average rate. I would say the average rate in the country is about $170 a month for a Medicare supplement at 65. Females get a lower rate. You get different, Florida premiums are about 25% higher. So it's going to fluctuate based off of age, gender, insurance company, and not your health history the first time we get into Medicare. So on this path, we're buying a Medicare supplement, and then we're going to add what's called a standalone drug plan on top of our Medicare supplement. And that drug plan is going to range between about $10 a month to about $90 a month, which is where most plans sit. And you can mix and match these insurance plans. So we can have a United Healthcare supplement and an Aetna drug plan, or vice versa. And I'll show you a little bit more about the drug plan and some of the changes that are happening next year. But let's call that about $40 a month just for our comparison. And then if you want dental and vision, it's a totally separate purchase. So we can add dental and vision through an employer plan if you still have access to that. You could take Cobra, or some of the plans that we sell are about $50 a month, paying up to about $3,000 a year worth of benefit. So this path all in tends to be about $400 a month on a low end if there's no IRMAA, up to about $1,000 a month if we add that top of the line surcharge. The negative of supplemental insurance is really just the fact that you have to pay these extra premiums whether you use the plan or not. So there's a meaningful amount of people that either can't afford a supplement or don't want to pay the supplement because they don't go to the doctor and they don't travel, and a local network is fine for me. I'm a homebody, and I go to the one doctor and he refers me wherever I need to go. And so I just can't justify spending all these premiums, plus they go up every year. And so that makes this other side more attractive to someone that has that opinion. And Medicare Advantage still requires you to pay IRMAA. So if you're making $1 million, you're still spending roughly $700 per person, right, for a husband and wife on Medicare fees, but then you could buy your Advantage plan for no additional premium on top of Medicare. And so everyone listening has probably heard about these plans that, the Joe Namath commercial and the JJ Walker commercial, and this idea that you don't pay an additional premium. That's true, but sometimes people don't understand that they still have to pay the Medicare fee that comes out of their Social Security check. So the catch, right, we still have to solve for the 20% prescriptions, dental, and vision. But the catch is that the government subsidizes the private insurance company. So we've got a lot of the same carriers that sell on both sides of the equation here. Someone over here might say, oh, I pay $200 a month for my supplement with United Healthcare, and I love it because I go anywhere I want and everything's covered. And someone over here may disagree and say, wait a second, I'm on United Healthcare, but I don't pay a premium, and I have a referral, and that specialist wouldn't take my plan because I'm on an HMO with United Healthcare. And the trade-off is that the government pays the private insurance company to manage the care. So what we're doing is we're giving up some freedom and flexibility to be, fee for service the other side. I go anywhere I want and everything's paid for in exchange for lower premiums. But the catch is that if you get sick, you've got some skin in the game. You've got about $5,000 of exposure on most of the plans. And that might be lower in more urban areas, and it could be much higher depending on where you live. But if you find that you're spending $5,000 every year because you have an infusion you need quarterly, it would be a fair question to say, well, maybe spending $2,000 a year to cover all that makes sense. But then you have to go through underwriting. So that's the trade-off, is if we start on Medicare Advantage and you don't like it as you get older because you find the networks to be more restrictive at that point, or sometimes people on Medicare Advantage won't like their plan because it requires that managed care, to get a specialist visit, you might need a referral, or to get a test or if you have a stroke and you need rehab, the Advantage company will pre-authorize X number of visits. And so sometimes you might want to have triple the amount of care, but your Advantage company won't see eye to eye with you, and now you're frustrated. Like that is probably more of a common reason people went out of this versus having to spend $5,000 because they got $1 million claim. So then you find that the only way to get rid of that pre-authorization is to come back to Medicare in a supplement. But again, at that point, you're 75, you're 80, you probably have developed health issues that prevent you from coming back over here. So when we go through door number 3, whether that's right at 65 or we delay our decision-making or our path to Part B, we are delaying this decision. So if we identify that your group plan is a better deal than what you have, then we are also just saying it's not worth messing with the rest of this right now. It will be at some point in time. Or if we're already on Medicare, you hopefully resonate with one of these paths. You either have bought Medicare and then pay for a supplement, and that supplement has gone up in price, and your drug coverage has changed on you, or you're on Medicare Advantage. And one of the things that we have noticed is that Medicare Advantage is not going anywhere. It is about 20 years old and is gaining in popularity. So some, and even the higher income space is starting to, maybe change their mind on Medicare Advantage. And hey, I've been on an HSA plan my whole life. I've got $100,000 in there. I can afford to pay the out of pocket. And these Advantage companies, as more and more people have opted into them, they've expanded their networks. Doctors that maybe historically have not been part of managed care networks are quickly realizing, shoot, we better change our attitude because this is where our patients are going. Whereas that last wave of doctors, like I think of my mom, everybody that she knew in healthcare really is retired now. And so the next wave of doctors that are coming in are employees of healthcare systems. So these large healthcare systems are aligned with Medicare Advantage. In our area in St. Louis, we've got Washington University, which is like one of the top teaching hospitals in the country, and they take 15 to 30 versions of Medicare Advantage. 10 or 15 years ago, that was not the case. Now, the risk is we don't know what that is going to look like in 5 or 10 years. Because this market is so heavily subsidized by the federal government, it's very unknown as far as what that subsidy is going to look like, and that directly influences the attractiveness of Medicare Advantage. And so one of the things we're starting to see is that with some of the laws that are being passed, the Medicare Advantage market is starting to kind of become under some more scrutiny, where these Advantage plans are maybe denying services that the federal government feels like they should be covering. And so there's lawsuits floating around. And then these Advantage plans also sell standalone drug plans. So the big Uniteds, Humana, Aetna, they offer multiple drug plans, and then they also offer multiple versions of Medicare Advantage all over the country. And one of the things that is changing during this upcoming annual enrollment period, which is our time to change. So as Lizzie said, we have from October 15th through December 7th of every year. That's your chance, if we're already on Medicare, to reevaluate your plan. So if you are not on Medicare and you're turning 65 next year in April, this window doesn't affect you. If you're going to retire in March of next year, this window doesn't affect you. This window only comes into play if we are already through door number 3, we've bought A and B, and then we've purchased some private version of supplement drug Medicare Advantage. So during this window, it's our time to reevaluate your drug coverage or look at switching paths. If you have a supplement, you can switch your supplement anytime you want during the year. That is a very common misconception, is people will get a rate increase on their supplement in the summer thinking, oh, I'm stuck till the end of the year. But no, you can change your Medicare supplement whenever you want. And then a handful of states, let's call it about 15 states, have rules that allow us to switch supplemental plans without answering any health questions. So if we started on this path out of 65 and now our rate is getting out of line, depending on where you live, we can switch you without answering any health questions to another version of that supplement. And the nice thing is that the coverage is the exact same. We're just doing that to save premium and kind of keeping these companies honest year over year. But as the people on Medicare have probably seen, if we don't do anything, no action's required. You just automatically re-enroll and renew into the same plan. But this is not the year to do that. And the reason why is because the Inflation Reduction Act that was passed in 2023 is changing the Medicare drug program significantly in 2025. So next year, all Medicare Part D plans, whether it's integrated into an Advantage plan or also on a standalone drug plan, are now adding a max out of pocket. So for the longest time, Medicare's drug benefit had something called the donut hole. Funny name, but it was kind of a frustrating thing for a lot of people. And in a nutshell, what it was is I had a bucket of money to spend on medicine. So if I was on insulin, if I was on some of these heart drugs, some of these biological medicines like Humira that are really expensive, and I was on Medicare, I would pay a copay for 3 to 5 months, and then I would fall into this hole where my price went up significantly. Like some drugs went from $100 copay to $1,000 copay for the rest of the year. And people stopped taking their medications, or they, didn't understand it and they thought it was broken. But that's just how the Medicare drug coverage existed from 2006 until 2025. And then the Inflation Reduction Act passed in 2023 said we're going to change that next year. And it's adding a max out of pocket of $2,000. So now that person, instead of spending maybe $10,000 on medication costs because they were on $100,000 a year worth of medicine, they only spend $2,000. So you could argue for that person, this law helps out significantly. And there are tons of people that is absolutely the case. But statistically, it's probably only about 5 to 10% of people on Medicare were in a position where they had so much medication costs that the old way was worse than the new way. For a lot of people, this is just going to be a net push. You're on 2 or 3 generic drugs on a drug plan that's $10 a month and you pay nothing for those scripts. This law really won't affect you on those medications. But where it is changing things is that these drug plans charging $20 a month, $60 a month are now responsible for paying a lot more for that 5 or 10% of people. And so what we're seeing is that the premium on the good deals over the last 5 or 7 years are tripling or quadrupling in price. So somebody might get a rate increase next year on their drug plan from $30 a month to $120. And it's not that you're getting ripped off. It's just that version of a drug plan is really being affected by this law change. So you might have that happen to you. And then the other issue is that we are seeing these plans reduce the number of medicines that they cover. That's probably the bigger issue, is if you're on one of these specialty drugs for MS, for Parkinson's, for Ozempic, for diabetes, you may find that your plan had covered them. And this is true on Medicare Advantage also. But now next year, because of this law, you may see them drop that prescription along with raising the premium. And then on Medicare Advantage, because everything's under one umbrella, we're seeing a lot of plans change some of the bells and whistles along with the drug coverage. Maybe they're adding deductibles for Part D for the first time. So now you have a $600 deductible, whereas the first 10 years on Medicare, you did not. Or maybe they're dropping a healthcare system or some doctors to offset the fact that they have more out of pocket on prescriptions. So this law is definitely something to keep an eye out on. And just if we're already on Medicare, it's worth looking at this year more so than any other year. And that's something that we can help you with. We do annual reviews for our clients at no cost every year, just to make sure that you're not missing anything obvious. And so to wrap up here, I would share maybe a couple of other little just kind of things I've learned. GoodRx and cost plus drugs were, sometimes there's medications that just are not covered by Medicare drug plans. And that's probably only going to get worse with this law. And so these are two great resources that you can use to buy dog medicine, skin creams for eczema that are just not on your list of your employer plan. Silver Sneakers is kind of a funny name, but if you're on Medicare, you probably know that name. That's an awesome benefit that we see most plans, even on supplemental insurance, now give, where you can go to different health clubs for free. YMCAs, Lifetime gyms, some pretty high-end gyms, you get access to them for free. And they have this kind of slick tuition benefit where every time you work out, you have to sign up for it on this website, but they will kick in like 50 cents to $1 towards a college grant for your grandkids. And so we have a few clients that really have they're going to work out anyways, but they're able to get $10,000, $15,000, $20,000 over the course of a chunk of time towards college tuition for the grandkids. So that's kind of unique. And then the last thing we get asked about all the time is dental coverage, because most clients that went with Medicare and a supplement and a drug plan opted to not buy dental because maybe it wasn't worth it to them at that time. And the dental plans have gotten, I wouldn't call it meaningfully better, but just better to the sense where we've got a few plans that are about $60 a month that will pay up to $3,000 per year, which is stronger than most employer plans. And right now there's no waiting periods for major services. So it's kind of one of those unique opportunities where I could sell you a dental plan today. You pay $60 a month. You could have 2 crowns taken care of. They'll pay half of the crown for a total of $3,000. And in theory, you could drop it in 2 months. So, that is something that we get asked about all the time. So I wanted to share that with you. And with that, I think we'll wrap it up and just say what to take away is that there's help out there. We work with people all over the country to make sure you have the right fit for your situation. Start a little bit earlier than you might think, because the Medicare system and the Social Security system, especially when we get into it after the fact, there's staffing issues. And so sometimes just starting a little bit earlier lets us avoid some of those frustrations waiting till the last minute, waiting for processing times that seem to take way longer than they should for some of the Medicare stuff. So with that, I just want to say thank you to everybody for attending, and I'll throw it back to questions and answers at this point.
Thank you, Karl. On the heels of you mentioning looking at things, don't set it and forget it. The first question, can you share some of the most common mistakes that you see people make? Specifically, let's start with the annual enrollment period that's coming up. What would you share with folks to be on the lookout for outside of or in addition to the changes with the Inflation Reduction Act?
I would say that the Medicare drug market, the Part D market, has turned into the cable and internet pricing strategy model where, clients turning 65 today are going to get in the weeds on this more than they ever are, right? I'm new, I'm price sensitive. I am willing to switch pharmacies. My grandma is 95, and to have her change a drug plan it's just not worth it to a certain extent at that point. Now, if she's going to save a bunch of money, we might just do it for her because we're in this space. But these drug plans know that. And so they'll give you a good deal for 3 to 5 to 7 years. And a lot of clients have that premium pulled out of their Social Security check or out of their checking account. So, I'm paying $20 a month because that's what it was 9 years ago, not realizing that it's gone up to 130. And you might have the same 3 or 4 scripts that you've been on for a long time. So I would absolutely say that that's probably the number one. If I'm already on Medicare, I don't want to reinvent the wheel, right? I enjoy the supplement. I go anywhere I want, but that drug coverage component. And then if I had to find some others, it's maybe being wooed into Medicare Advantage by the shiny objects, the free over-the-counter perks, and we had some plans this year that paid for golf clubs, that paid for lift tickets to go skiing. And that's great, but is that really going to last? I mean, and it didn't. Now we're seeing next year, when everything kind of changes, that those freebies are being yanked away from people. And if you changed and you have cancer now and you want to get back onto a supplement, you feel bait and switch. So I would, those are nice to have. And if we're leaning towards Medicare Advantage, let's make that a tiebreaker between 2 or 3 plans, not the main motivation. And I would say that dental is the number one wish list of all the ancillary benefits. So if we're looking at Medicare Advantage, personally, I would say like network, copays, PPO versus HMO, like that type of stuff. But then I'd probably rank the dental benefit embedded in those plans to kind of, make my decision. So I would say those are probably some of the more common mistakes we see.
Okay, great. Can you provide some clarification on the PPO versus HMO?
Sure.
Decision?
So Medicare Advantage is network based, right? So if I buy a Medicare Advantage plan in Indianapolis, Anthem, Blue Cross, and Blue Shield is really competitive in your area. So I would enroll into Medicare, pay Medicare my fee, and then I have a decision to make on which version of this I select. And the HMO plans are going to be more attractive looking on paper, right? So in exchange for a lower copay at the doctor, a lower max out of pocket if I got really sick, I might further reduce my access to care to chase that lower copay. So an HMO stands for Health Maintenance Organization, and that's what we understand like old school HMOs. I have a gatekeeper, like a primary care doctor, where I may or may not need a referral to see a specialist, but I have in-network care really kind of around your backyard, about a 200-mile radius around your area, your residence is your network. And if you want to go out of the network and access a specialist here in St. Louis or at Mayo Clinic or something, an HMO plan will not allow you to do that. And so you gave up that flexibility in exchange for a lower copay. A PPO plan is a notch above an HMO, but a PPO plan is not as open as original Medicare with a supplement. So a lot of people get that false sense of security sometimes where they opt for a PPO thinking that is the most widely accepted version of Medicare. And I would argue that it's not. Original Medicare with a supplement is the most widely accepted version of Medicare. But a PPO plan would open up that network and as more people have opted for Medicare Advantage, right? We see this chart from Kaiser on here. One of the big limitation, if I'm a high income client and I travel a lot, it's this idea of boxing myself into a network locally to where I live. I spend 6 months outside of that area. What if something happens to me? Here, I can look you in the eye and say, you just go anywhere you want that Medicare is accepted. And even if you bought your supplement from Indiana, it will pay 100% at Moffitt Cancer Center in Tampa. Just go and it's paid for. On a PPO plan, you have access to a larger network, but the providers still have to agree kind of on a case-by-case basis to take the terms and conditions of the plan. So the PPO is more flexible, but it can sometimes not operate the way you want it to in that emergency or that crisis situation.
Okay, thank you. You mentioned that the IRMAA brackets will be indexed for inflation. There's going to be new plan information related to Part D and B. When is that information available to you versus to the public?
I kind of know what's out there. I'm just not allowed to spill the beans until after October 1st. Clients are already getting their own, that's called an ANOC, Annual Notice of Change. Mm-hmm. I hate that acronym, but it's catchy. But that is your plan sends you this comparison of here's what we did this year. Mm-hmm. Here's what we're doing next year. And we have clients email us like September 1st with, I got my changes. And it's always funny because it's like, well, technically I can't tell you until October 1st, even though you got what you received. And, so it's kind of funny, but October 1st is when everything is uploaded like online on the Medicare.gov site. Mm-hmm. And then we have software tools that we can then kind of, hit refresh on October 1st, and it will have the new formularies. Mm-hmm. So we use August, September. Our agency is kind of like the fact-finding stage. So we send our review forms out. We want to, clients that have called us in April and May with like, I'm on this plan, now something has changed. My local pharmacy closed and the only other one is, halfway across town. We'll start contacting those clients today to set up meetings in October. So that way we know that, they've expressed frustration or, I'm on a supplement. I want an Advantage plan. I'm going to switch even if you tell me not to. Like, okay, I want to be the one that writes it because those companies pay us. We'll set that meeting in October to make sure you get the right setup for you.
Okay, good. And if folks want to do research on their own after October 1st, I heard you mention Medicare.gov. Are there other resources you would recommend in addition to that?
We've got a bunch of Medicare 101 videos on our website. So they're I think good 1,000-foot views. Sometimes we get way too far in the weeds and we're comparing 3 versions of Blue Cross to 3 versions of supplemental and people's heads start spinning. So I think we do a pretty good job of like, here's the enough to make you dangerous. And then if you want some more info, go watch the next video type thing. The Medicare.gov site is pretty, love it or hate it. Like it's pretty exhaustive and pretty helpful. You just have to know how to navigate it. Mm-hmm. We have tools if clients want to email like, hey, here's what I'm on. Do you see anything wrong with that? I'm not ready to talk to you. I don't want to, bother you with like, I just like to do some more research. I'm happy to look at what they have and maybe throw it into our software and give them like, if you wanted to move 1 notch left or right, here's what I see. And it might save you $1,000 a year or something like that. Mm-hmm. But friends and family, but you just have to watch out with friends and family because they may mean well and give you advice that's specific to their situation. That might not be, exactly what you're wanting. Yeah.
It was interesting. I was playing pickleball the other day and I heard folks talking about Medicare choices that they were making. And it was very much a friends and family conversation.
Yeah.
Okay. I think the last thing that I would ask is I heard you say that exploring Medicare enrollment 4 to 6 or even more than 6 months in advance is advised. If you're going to actually enroll, what's the typical processing time to expect?
So if a client's not drawing Social Security, mm-hmm. let's say their birthday's January 1st, we can sign them up for Medicare A and B, usually about 4 months before their actual birthday.
4 months. Okay, good.
And the correct answer is that sometimes I've seen those enrollments process overnight, 24 hours from when we signed up, they get their Medicare approval. I've also seen that take 90 days.
Okay.
Why did one take 24 hours and the other 90 days? Did I do something wrong? Did I hit enter twice on one application? Maybe, but I think it's just, if you've always had a frustrating experience with the government, like I think of I had the wrong Social Security number in the system for like my whole college career. So I was like a nobody and I fixed it, but something like that probably pushes me towards it's going to take a lot longer because these systems that are automated are just pinging multiple databases. And if everything checks out, then no human needs to look at this approved. If you've had identity theft, if you have a junior on your name on half of your stuff, but then the other half you don't, or you got married, changed your name, then got divorced and changed it back, stuff like that is probably going to shift you more to the 90 to 100 day processing time.
Okay, that's helpful. That's good. Well, thank you so much. We'll wrap it here. On behalf of Evans May Wealth and our clients, we appreciate your insights. And to those of you who have joined us today, we hope you found value as well. Please let us know how we can help you and your family. And thank you again for joining us. Have a good evening.
Take care.
Thank you, Karl.